malignancy is suspected, please advise core biopsy. When preoperative immunohistochemistry is required, such as breast carcinoma, we need ERPR HER2 status to give neoadjuvant therapy. Please advise core biopsy. So in a nutshell, we can advise core biopsy to breast lesion, lung lesions, liver lesions, CT-guided core biopsy in case of internal organs, and any lesion that exceeds the size of 2.5 cm is a good candidate for core biopsy. So these days, actually, only reason not to advise core biopsy is if the patient cannot afford it, or the lesion is too small. However, it has pitfalls, like some tumors range from benign to malignant, like cyst, fibroid, phylloids, desmoids. Some part of it may remain malignant, other parts benign. In this case, core biopsy failed. Everything has their pitfall. There is a conception that bone biopsy may not be possible, but actually, in a bony pathology, the bone becomes very fragile, and bone biopsy can yield excellent result. I'll just show you an example. She was a student from Tmmc Nursing College, 19-year-old girl with a tumor in the knee. You can see the biopsy needle going in the lesion, and can you please enhance this image a little? Thank you. Stain is not very good, but if you can see, there are cells, there are giant cells with multiple nucleus, many nucleus in one cell, and these are giant cells. I think Abbas sir already made the diagnosis. This is a knee joint tumor with many giant cells. What do you think it is? Anybody please? This is a giant cell tumor of bone. Very diagnostic in core biopsy. Next please. We don't advise cervical smear enough. A cervical smear should be advised to every woman above the age of 21 years or after being sexually active 3 years after. This is the WHO guideline to healthy women, not unhealthy. And underage pap smear is not really necessary before 21, unless otherwise there is indication like discharge or anything. And this report should be done by a pathologist. There are other specialties like clinical pathology. This report was done by clinical pathologist and the report came normal. This was again sent to me, referred by my mother, who happens to be a doctor also. And I saw it's a high-grade lesion. And later it was sent to BSMMU, and in biopsy it came a high-grade lesion. So if the patient did not do the repeat pap smear, she would have gone on to develop cervical carcinoma. She would require major surgery followed by many cycles of therapy. And even then the chance of survival would be less. So that's why every specialty has their own field. Cyto and histopathology has to be done by a pathologist. This is my thesis research on cervical smear. We did a newer method, liquid-based cytology at BSMMU for the first time in Bangladesh, and since then it is available in BSMMU commercially, but it is available in ResearchGate if you want to look it up. Why am I sharing this? Interestingly, in our research we found out that even though it is costlier and it has some advantage like reflex testing, the accuracy and specificity are almost as similar as conventional. So right now in our country we don't need costlier methods. The conventional yields good enough result. We just need to implicate it. Synoptic reporting. In a malignancy, the reporting should be done in synoptic pattern provided by College of American Pathologists, CAP, adopted by WHO. If you don't get a synoptic reporting in a malignancy, please demand for it to maintain the international standardization. Just take a water break. Another story, please bear with me. I got a tubular BT sample, bladder tumor. There was no muscle present in it, so I gave the stage T1 and no muscle present, I mentioned it. The patient went back to the urologist and the urologist collected the muscle again and sent it to me, but the tumor was not involved. So the stage remained T1. In bladder tumor, it is called T2 when it is involved in muscle. So the patient went to Asana Mission Cancer Hospital. There's a doctor received him, an MBBS doctor who was aiding the oncologist. He saw the two reports and he said, the histopathologist mistakenly given you the same report again. It's T1 in the first report, T1 in the second report. It should be T2. This time muscle is present. The patient came to me angry, charging, annoyed. Why are you doing this to me? You're making me run back and forth. You gave me the same report again. So I called the doctor and I asked him, and I explained to him, the muscle is free of tumor. It will remain T1. He said, oh, okay, send him back. So what happens is, in the meanwhile, the patient is being annoyed. And in his mind, maybe he is planning to go to India. And saying to his relatives and surrounding, there is no treatment in Bangladesh. Even though everything is being done. Another controversy we face, the endoscopist is seeing a malignancy. Even I will agree it's a malignancy seeing the endoscopic picture. A very ulcerating fungating growth, I agree. In my slide there is no malignancy. What to do here? What should the surgeon do? Everybody in mass confusion. What happens? Every malignancy has a superficial ulceration. In the endoscopy it is seen. If the biopsy is only taken from the ulcer, I will not find any malignant cell there. That's why to exclude malignancy, it is a protocol. It is recommended to take at least 6 or 7 pieces. 90% of time, we get 2 or 3 pieces. So these are the uncertainty phrases sometimes we have to use. Like suggestive of. This means you have to correlate with clinical condition, with history, with tumor marker, with further evaluation if necessary. Even in international standard, these terms are present. In Bethesda category of thyroid, there is a term atypia of undetermined significance, category 3. In cervical spine, there is a term atypical squamous cell of undetermined significance, ASCAS. So these are internationally adopted terms that sometimes has to be used. C description please. Many times clinicians are disappointed with a C description please diagnosis because what to do with it? This can happen again from a very reputed lab in Dhaka. It's a very favorite lab for the ENT surgeons. They prefer it very much because they do give very good diagnosis. The diagnosis is C description please. Why? Because it cannot separate between a minor salivary neoplasm and squamous cell carcinoma. What to do in this case? You have to go for immunohistochemistry. This is again one of those descriptive terms. Cellular follicular lesion in thyroid can range from adenoma to carcinoma. There are some newer terminologies. Encapsulated follicular variant of papillary thyroid carcinoma. Whenever I give this diagnosis, many times the ENT surgeon calls and says whether it is benign or malignant. Then I have to explain it's an indolent malignancy. It is malignancy, but it will not spread. This is a category that is newly introduced by WHO. And many values have changed. Even I have taught in my class that in semen analysis, the motility has to be 60% in first hour. I have taught myself, but these days WHO is telling it has to be only 32% in first hour. The morphology, we used to tell 40 to 50%. Now WHO is saying only 4% morphology is suffice to call it normozoospermia. Even the count is decreased to 15 million. Previously it was 20 million. So you have to be accustomed with the changing values and terms also. We are all in a hurry. When we send the sample, we are all in a hurry to get the diagnosis. Obviously, it's a matter of life and death. So because of that, we the histopathologists have to be very careful. Say a Whipple's operation is sent. It takes long time to do the operation. It takes long time for us to do the grossing also. A large Whipple's sample, to take out the tumor and the margin, it takes like 45 minutes to 1 hour. After that, the processing, from this large sample, a small slide is made. This process takes 3 to 4 days. Now in that slide, I did not find the malignancy. Maybe it is in deeper tissue. We have to do a recut. It will take another day. Maybe the invasive margin is very much ulcerated. I cannot be confirmed. There are special stain, like PAS, to apply to see the breach of basement membrane. We don't apply it routinely because it is costly. So when we apply it, when necessary, it will take another day. And maybe in the meantime, a Friday also happened. So in all the process, the report is sometimes delayed for very good reason. Total count is 15,000 and lymphocyte is 70%. Do you think it is normal? Is it normal? Many are nodding no. It's not normal. But if these values are of a 1-year-old child, is it normal?
Yes.
It is normal. Abbas is saying it is normal. So our pediatrician head sir is saying it is normal. So we have to keep in mind, remind ourselves that under 5 years old, the total count will be raised. Not necessary to go for antibiotic or think of sepsis unless it causes the international value. Today Google is available, everything. You can just go up and look for the values. But below 5 years, lymphocyte differential count will be more, total count will be more. The values we commonly remember is for adults or above 5 years. Many times platelet diagnosis can be wrong, so it must be rechecked manually. Because many times machine can give a false diagnosis due to giant platelets, stereotosis, cytoplasmic fragment, dust. Machine sometimes count dust particles as platelet. Sometimes the blood could be clotted before examination. So these all things should happen under manual observation. This happened, I was getting a CBC report of leukemia. So I gave it, there was no PBF, so I just gave it there a blood cell, I mentioned everything. But they were repeating it. They were sending me again like 3 times in a row, they were sending me the CBC. That time dengue was at rampant. So they were probably just focusing on the platelet, whether it is decreasing or increasing. They were not seeing the blood cell in the report. So I later called up, told them this is actually a case of leukemia. So thrombocytopenia can also mean other diseases. We have to exclude everything based on the whole report. And when confused, we must advise a PBF. This is an example of a good communication. I made a FNSC and the diagnosis was epidermal inclusion cyst. Later it was biopsied and sent to some B2B lab to India. Some lab in India, I don't know. You can see the diagnosis. They said it's squamous cell carcinoma. So the surgeon called me. What happened? I went back to my lab, checked my slides, took the photos and sent to surgeon. This is an inclusion cyst or sebaceous cyst. No doubt. You please send the sample to some other lab, if not me. And he sent the sample to another lab and it came epidermal inclusion cyst. So because of the communication between me and the surgeon, many confusions could have been avoided. So we'll just end with some food for thoughts. What do you think about this question? Is India and Western world better than us in diagnostic pathology?
I don't think so.
I think all of you will agree, yes. But this is not an absolute answer. This is not an absolute answer. I tell you what, I had a diagnosis of ductal carcinoma of a doctor's relative. She was immediately sent to India through some marketing agent maybe. And I followed up. I kept asking what the diagnosis came there. They stayed there for 3 months and ran multiple of tests, lakhs of rupees spent. After 3 months, they agreed it's a ductal carcinoma. After 3 months. In the meanwhile, she developed axillary metastasis. The doctor later really regretted to me. So I'm not saying we are far ahead than them, but we are not far behind also. In my experience, I have seen poor patients in our country get good treatment. They don't question the doctor, they don't analyze the doctor, they take the treatment, they follow the instruction, they recover. Hundreds of thousands of patients around Bangladesh in government and private medical college. How are they getting treated? Not everyone can afford to go to India and Singapore. How are they staying healthy? How are they recovering? Because they are giving good compliance to us. What happens with the rich people or well-off people? They see one doctor, they recheck it with another doctor, they WhatsApp the prescription to a relative first-year-old medical student, to verify if the professor is right. And eventually goes to India. All in the meanwhile delaying and complicating the disease. So we do make mistakes, but I think with better communication between us, between patients and doctors, media and society, we can really win back this fraction of trust that we have lost recently and stop this or reduce this outflow of patients to outside country, inshallah.
Inshallah.
Thank you. That is my presentation. If there is any question or query, anyone wants to add anything to it?
Thank you very much for wonderful presentation of a beautiful topics.
Thank you, sir.
Because this is a very everyday case. It is happening, and our Dr. Mehdi Ashik Chaudhary, he has nicely delivered his lecture, which is so palatable, understandable. Everything was fantastic. So everything was fine, but my addition to this discussion or this today's CME discussion, 2 or 3 things I want to mention. One of my close relative, she was a young lady of 25 years hardly, and she delivered a baby, and during that time the gynecologist diagnosed her as a cervical cancer and asked her to come after post-pubertal period so that further investigation evaluation can be done. But they didn't go to that gynecologist, but they are money person and they left for India. And India, they stayed over there more than 3 months. That is taking too much time. Probably the standard of that clinic where she was there attended, probably that much standard. So they had to send the samples to Delhi, and from where report came at least more than 1.5 months into, and huge money. And he said to me that yes, 3 or 4 times I had to bring money from Bangladesh to continue my treatment. But they were telling that no, you don't have to worry because everything is fine. And patient was relatively fine in that case, because the whole thing after laparotomy, everything was taken out. But the party, when everything was over, and I shouted at that person, male person, because he was relative to me, that you do not understand anything, you are just goblet fool. Because when everything was taken out from the lower part of the body of that lady, and it was mentioned clearly in the reporting file, in the papers, but they didn't go for that reading in papers. After 3 months of staying in India, they came back and they were fine. After 2 years, suddenly the patient developed severe abdominal pain, right-sided, and patient admitted to Somerset Hospital. And at night, I went to there. I found that no, patient is again transferred from Somerset to BRB Hospital in ICU. Patient became shocked, and patient expired. And when patient is in between life and death, that husband of that lady was talking, no, probably they are doing business, and that is why my patient is put into the ICU. But India was fine. Then I told him, after seeing the papers, that your patient is having carcinoma, cancer. And that cancer has been spread to the liver, whole liver was involved. And by that time, liver failure and shock, everything was there. But see the conception of a person who is living in the Dhaka. Every facilities were there, but they did not read the papers that yes, the cancer, and they were supposed to go back to that clinic for further follow-up. They did not follow anything. So this is happening in many of the families where the patients are suffering in this disease, from this disease. Another thing is, when you are going to abroad for treatment purpose, you are getting an appointment. I'm taking a little bit time, sorry. Appointment. And over appointment, a provisional diagnosis they put, the consultant from the abroad. Then they make a fund. Yes, you need to come here for at least taking 7 days in your hand, and with this was budget. When budget is there, and my doctor, Indian or whatever is the country, the foreign doctor, when find that patient in front of him or her, is sitting, he or she knows, the doctor knows that he has come with full funded preparation for the management or treatment. But here, today, I saw one patient of 42 days old, suffering from cough for the last 30 days. At least out of 42, 30 days cough, and in X-ray showed disseminated patchy opacity with both the lung fields. I told her to admit the baby. Baby was not admitted. So this is happening, and the patient will suffer. But when a foreign doctor found a patient of him that after appointment has come with this much fund is full, they used to do all the investigations. And another patient I saw went for endoscopy in India, Kolkata, and there was perforation in the lower part of the esophagus and admitted to the Samarkand hospital, and the patient ultimately died because of infection, because it was lately diagnosed. So it is happening, and people will be going outside. But I must congratulate those people, even not only doctors, the quacks in the peripheral region. The hundreds of patients are getting treated from those pharmacy men, and they're doing well. And it is accepted by our government that the rural medical practitioner, up to certain drugs or certain limits, they are treating. Otherwise, 200 or 160 to 180 million people are being treated by the local doctors, and particularly the COVID period, 2 years, no one could go outside. Even Babul Chaudhary, he could not go outside, and he died in Evercare Hospital after suffering from the COVID. So during that time, the Bangladeshi doctors treated all the patients of these Bangladeshi patients. But still the non-medical, even your close relatives, sometimes they cannot trust on you. So the trust has gone. It is of two causes. One is ourselves, another is people expectation is different. I don't know what they expect. Here, the person who is shouting at Tmmc, if that patient goes to Dhaka Medical College, he will not be able to utter a single word even. So that is the thing, the mental attitude of the people of Bangladesh, particularly those who are coming to seek treatment. They are not, particularly for doctors, they are not good for the doctors. Even in the media, even in the politicians, they are always shouting against doctors. You will see, the last president also shouted, oh, you are taking 600 taka visit. It's too much. Not only once, more than 3 or 4 times in different seminar symposium, he told this.